Good afternoon, everyone, and welcome to Grand Rounds. Before we start, I wanted to take a quick moment to thank Avela Bank for their continued and generous support of the CME programming at MGMC. Their support has been really instrumental in furthering the mission of the CME committee, as there is a significant associated cost with putting on the programs. Also, I wanted to welcome back everybody who's in attendance in the auditorium. It's been a long 2 years, and I guess maybe it's somewhat fitting that our topic today is a non-COVID related ID topic. Today, it's my pleasure to introduce Dr. Dan Fulton. Dr. Fulton attended Iowa State University before attending medical school at the University of Minnesota, did his residency at Hennepin County, his ID fellowship at the University of Iowa. He's been really active in several educational venues over the last 2 years, primarily educating us on all things COVID related. And today, somewhat refreshingly, actually, his topic is Antimicrobial Stewardship. The title of his talk is Bugs and Drugs, a Collaborative Approach to Antibiotic Stewardship. And please join me in welcoming Dr. Dan Fulton.
Thank you. Can everybody hear me okay? Good. Well, thank you, Dr. Hallberg, and I can't say how nice it is to see you all back again. Thank you all for being here, and for everybody still online, we're glad you're here too. So we're going to be talking about a non-COVID thing today, which is great. I don't have anything particularly to disclose, although I would note that our COVID numbers are fantastically low right now, and we're just rolling with that. So antimicrobial stewardship is probably something you've heard of. Many of you are involved in our process here. Some of you may have kind of a more vague notion of what it is. And I hope to just sort of dispel some myths about it, make sure you know how our program here works and how these programs work in general. And we're also going to talk a little bit about some treatment guidelines and treatment approaches that are kind of commonly assessed and addressed in the role of stewardship. So let's start with a case. This is somebody from last week. So this was an 83-year-old man with Parkinson's, and he has some urinary retention with his Parkinson's, but had been doing well with once daily self-cath. He had a recent UTI and got some oral antibiotics, but then he came in with sepsis, and he couldn't empty his bladder, and that's probably why the sepsis happened. So in his initial evaluation in the ER, he had a positive urinalysis, and his bladder was full, so a Foley catheter was placed, and cultures were sent. And then he was started on ceftriaxone empirically from the get-go for what was presumed to be a complicated UTI. So complicated UTIs are pretty common. Any UTI in a male is considered complicated by definition. Usually it's caused by E. coli, but other gram-negative organisms are possible. And gram-positive organisms like staph or strep are even less likely. So in this setting, he has a positive UA, he does self-cath, which can introduce bacteria into the bladder, and we didn't have an alternative diagnosis, so the UTI seemed pretty likely. So if we look at the treatment decisions that needed to be made up front, his team did a great job. They got source control by putting in a catheter, and they chose an antibiotic which would be reasonably expected to target the organism most likely to be causing his illness. I can say from a sepsis standpoint, it was fairly mild, so he wasn't somebody that needed a very broad approach up front because we had a little bit of space for uncertainty if he were to have gotten worse. So I think that's always an important question with antibiotics. How willing are you to be wrong? Somebody that's in the ICU on vasopressors, very, very ill, you cannot be wrong. So then you start more broadly. In his case, we could start a little bit more focused with the ceftriaxone. And then how are we going to follow how he does? We're going to follow his clinical status, his fever, and his white blood cell count. And then those, the blood and the urine cultures were sent. So you may see some of these cards around the hospital. They're in a lot of the workrooms. This was a discussion we did a couple years ago about general antibiotic approaches. You can find it in the Grand Rounds library. It was called Antibiotics 101, and I gave it just like 2 months before the pandemic started, which seems like another world. But when we think about syndromes of what people are coming in with from an illness standpoint, we think about what bacteria cause those syndromes, and then we ask ourselves how sick the patient is and how aggressive we need to be, and then we pick an antibiotic based on what we think will reasonably cover the organisms at hand. So everything they did here was exactly right, seemed very reasonable, and 10 hours later, there was a call to the overnight team that he had a positive blood culture. So blood cultures, when they're drawn, they get put into the incubator. There's a carbon dioxide detector on the top, and so these are done in a continuous real-time fashion. And as soon as the detector sees something happening in that bottle, it gets pulled, and a gram stain is done to see what type of organism is in there, and it's a critical result that gets called to the physician. Additionally, a PCR test on the BioFire gets set up to look for what type of organism might be there, and generally speaking, that takes about another hour, sometimes 2. So that's an important distinction because the critical result gets called immediately, and it's not for another hour or 2 that this PCR result comes through. It also gets set up for a full culture and identification, and that usually takes another day or 2. So this is what his BioFire result was, and I think you can see here that he had a positive result for the family of Enterobacteriaceae. So this just tells us that it's a gut bug. And then when we looked at the specific targets of different gut bugs, he had an E. coli that came positive. And that's how these platforms work. They try to identify first the family, like a staph infection, and then they try to get to the species level after that. PCR testing has really revolutionized infection treatment and antimicrobial stewardship because we get so much more data early. We get a bacterial identification within an hour of a positive culture. We can often see if something's polymicrobial. We can look at gene resistance analysis, and sometimes can even help your patient not get an antibiotic if you're able to tell from this that maybe it's a contaminant. The weakness is that it doesn't give you direct susceptibility data, so you don't know for sure what antibiotics will work. You may know what won't work. And it is possible that although we can predict some resistance, there might be resistance mechanisms that we don't have the genetics for. And rarely we get a series of false positives. For a couple months ago, every culture we did was getting like an Acinetobacter positive. And usually when that's happening, we work with the lab to just suppress that result if it doesn't seem clinically appropriate, because otherwise it's just kind of confounding. So when you get this positive culture back, you get a call that it's E. coli, and you kind of expected that anyway. So then you can go to our antibiogram. So this is something that's maintained by our microbiology lab, and it looks at the probability of something being sensitive to a particular antibiotic. And so in this case, you can go to the E. coli, and then you move over here to ceftriaxone. So of all of our non-urine isolates, 94% of the time, E. coli will be sensitive to ceftriaxone. In this case, it seemed like a pretty good bet, and like I said, we had a little wiggle room with him. He wasn't critically ill, and so the ceftriaxone was continued. And so then the following morning, the team got this message. So this is a message from our antimicrobial stewardship team. So our team of pharmacists are reviewing culture data and antibiotic data. And they said blood and urine cultures are positive for an ESBL E. coli that's resistant to ceftriaxone. Please consider switching the ceftriaxone to something such as ertapenem. And so anybody that's the attending on patients is quite familiar with these messages. These messages are coming through regularly from our pharmacy team. And this is called a prospective review and audit. where the team is watching for anything that doesn't seem like it lines up. So you might say, well, wait, you just told us that ceftriaxone was a good choice. But if we go back to our PCR, one thing that you may or may not have noticed is up here on the genetics part of this, CTX-M was a gene that was detected, and that confers ceftriaxone resistance. The challenge is that these change from time to time, and it would be hard to expect every physician, every frontline provider to know all of these all of the time. So although this data was available, it's not uncommon that people may not know what that means or may not think it's relevant to their particular treatment. From the standpoint of stewardship, that's something that we're able to keep track of very closely in coordination with the lab. So we would know up front that this is a resistant organism, leading to this message. And even though the culture and susceptibility data were not yet available, our patient was able to get switched to an appropriate antibiotic. There are many different mechanisms for resistance of bacteria, and so we can predict some of the genetic basis of those, but there are other mechanisms as well. So in this case, he has an ESBL E. coli, which is an enzyme that chews through certain beta-lactam antibiotics at a high rate. And we knew he had that because of the genetics. It's possible to have other types of resistance as well, although fortunately those are more rare. And you can see that there's a lot of different resistance mechanisms, and there's a lot of different antibiotics. So there's just a lot to keep track of here. So he gets switched to ertapenem. He gets better. 2 days later, we finally get some susceptibility data where we're actually testing the organism against these antibiotics. And it's not just the genetics, it's does the organism grow in the setting of this antibiotic. And that did indeed prove that, yes, this was resistant to ceftriaxone. It was sensitive to the ertapenem. And we were able to move forward with his treatment from there. Now, if the provider involved would have said, aha, nitrofurantoin is sensitive, I'm going to use nitrofurantoin to treat this infection, they would have gotten another message from stewardship saying nitrofurantoin is only active in the bladder and your patient had bacteremia, so consider using an antibiotic that is also active in blood. So that's an example of what stewardship is kind of watching for. Generally speaking, with gram-negative rod bacteremia, there's a few things over the years that I think have evolved and changed. Specifically, you don't need to get repeat blood cultures for most gram-negative rod bacteremias. Gram-negative rod bacteremias resolve with antibiotics and source control, and they're very unlikely to create any sort of endovascular or persistent bacterial process. For Staph aureus or Enterococcus, you need to prove that your cultures are negative every time. But for gram-negative rod bacteremia, you've got a young person with pyelonephritis. If they're clinically improving, you don't need to feel obligated to repeat their blood cultures. One common question is, when can we switch to oral antibiotics with bacteremia? Generally speaking, if the patient's gut is working, they're clinically getting better, the organism is susceptible, and you have an agent that has good oral bioavailability, you can switch to an oral antibiotic to finish your course. Gram-negative rod bacteremia does not require a full course of IV antibiotics in most circumstances. The usual duration for gram-negative rod bacteremia treatment, I think there's a joke about infections and infectious disease doctors that we only think of infections in football scores, so 7, 10, and 14 as far as treatment goes. And so I think the reflex for bacteremia is 14 days, but actually multiple studies now have shown that for a patient that's gotten better, really 7 days to 10 days is sufficient. You don't have to push out to that full 14 days of antibiotics. The key is to pay attention to your patient, and if they've got undrained abscess or a deep-seated infection, then that's when a longer course of antibiotics is going to be necessary. And Pseudomonas is a bit of an exception because it's more resistant, so sometimes longer courses are necessary there. But for your run-of-the-mill transient bacteremia associated with cholecystitis, pyelonephritis, or UTI, a a 7 to 10 day course is going to be enough. So in summary, he gets better because we were able to get him to the right antibiotic sooner through the help of Stewardship identifying this bug-drug mismatch. I think he probably got better more quickly, his length of stay was shorter, and he had less of a risk of a bad outcome. And this really is a team effort between the frontline physician who was making excellent decisions and made the correct assessment up front, the micro lab who stays up to date on technology and gives timely information, and then the pharmacy team with Stewardship giving prospective feedback. Additionally, each time this prospective feedback happens, there's an education component. So the provider is learning, oh, hey, that CTX resistance is a thing that I can look for. And so the next time, they're more likely to pick it up and respond to it. And it's really important to say that all of this is supported by our administrative team because this all takes time. Before we leave the topic of bacteremia, I just want to go through this a little bit more. So Staphylococcus aureus bacteremia is a big deal and has a 20% mortality. And infectious disease consultation is independently associated with decreased mortality. So generally speaking, anytime we see a Staph aureus bacteremia, the microlab actually alerts us to that if we're not already involved, and you can expect us to be involved on that. The reason is that these patients need a minimum of 2 weeks of IV antibiotics, and that's 2 weeks is only if they get better right away, you were able to find the source and remove it, and they don't have any signs of endocarditis. So this is something we take very seriously, and by all means give us a call if your patient has a Staph aureus bacteremia, because it will always surprise you. From the standpoint of the PCR testing, I think this is helpful to look at. So here you can see we identify the family name that this is Staphylococcus. Then we identify the species name that it's Staphylococcus aureus. And then we are able to identify that it's actually MRSA Staphylococcus aureus because it's got the gene that confers MRSA resistance. The opposite would also be true. If you've got a person with Staph aureus bacteremia with a negative MECA gene, then they have sensitive MSSA infection, and you can probably narrow their antibiotics. You can stop their vanco and give them cefazolin or nafcillin, kind of the first-line therapies for MSSA. So you can leverage these PCR studies to help you make treatment decisions earlier than we can if we're waiting for culture data. Coag-negative staph bacteremia is much more common because it's often a contaminant. This is found on your skin, and it actually is found in about 5% of all blood cultures. The grand majority of those are contaminated specimens. This is why we get those 2 paired blood draws when we draw blood, is so we can see, is this in only one bottle? It helps us identify contaminants sooner. And so I guess what I would suggest is if you have that patient in the middle of the night and they had some blood cultures, but they're pretty stable, and you get a call about a positive culture and it says it's gram-positive cocci, you might wonder, is this Staph aureus? And you might be tempted to start vancomycin. But remember, if you wait just 1 hour more in a fairly stable patient, you may see that this actually is not Staph aureus, it's Staph epidermidis. And if it's only in one of the 4 bottles, it is almost certainly a contaminant. So sometimes waiting just a little while for this PCR result can save your patient from needing to get antibiotics. If you're worried about your patient and they're sick and you don't want to wait, then you would repeat the blood cultures and then you'd add vancomycin after that, and then you may find out it's a contaminant later. And I would say with coag-negative staph, beware if your patient has endovascular hardware like a prosthetic valve, joints, or has unexplained back pain. These organisms can cause deep-seated infection, but usually it's associated with one of these things. And then finally, maybe. Okay, so for strep bacteremia, this is associated usually with some pretty definite illness. They have cellulitis, pneumonia, meningitis, an abscess, and beta-lactam antibiotics are incredibly active against strep infections. And once the patient is clinically stable, usually after a couple of days of IV therapy, it's usually okay to finish the course of therapy for bacteremia with an oral antibiotic. Usually beta-lactam at a higher dose, like amoxicillin 1 gram TID. You can see here, this is another example. It found strep species. Then it looked for a couple different specific types of strep, which it didn't find. So this is probably one of the 30 other types of strep, like strep intermedius or strep mitis or something. And I guess I would say that that's an area where you might want to beware when it comes to strep bacteremia. If you have a patient that has this without a definite illness of cellulitis or pneumonia, you would want to consider looking for an endovascular source, because strep is a cause of a slow onset endocarditis, which if you didn't think of it, you might give this person antibiotics and they would look better for a little while, but as soon as the antibiotics were stopped, then that strep may relapse because it was at a deeper site. So again, it always gets back to that question is, does this finding make sense with what I know about my patient? And that helps you decide on treatment. Enterococcus is similar to strep in that it's usually associated with a definite illness. They're often contaminants if you only find it in one spot. If you have questions about, do I need to go looking for an endovascular source, there's this de novo score where you get points for these de novo categories. And basically, it's how many cultures are positive, are there signs of an endovascular source, and do you have another explanation? And if you don't, then you should think about getting some echo studies to look and see if there's any evidence of endocarditis. And I can tell you, enterococcal endocarditis, the typical story is a patient that comes in with some non-specific symptoms. They don't have a definite illness of biliary, colon, or urine, and then their blood cultures are just all positive for enterococcus. It's an organism that is not highly pathogenic, so it doesn't make people very sick from an inflammatory standpoint, but it is incredibly difficult to kill, and it does local structural damage, so it can really wreck people's heart valves. So take it seriously if you're having a lot of positive cultures, and you'd want to show this one was gone before you'd send the patient home. Enterococcus can be very resistant, so there's something called VRE, vancomycin-resistant enterococcus. And usually that's going to be Enterococcus faecium versus fecalis. And actually our PCR test does look for each of those up front. So if you have Enterococcus fecalis, that's most likely going to be vanco-sensitive. If you have an Enterococcus faecium and your patient is very ill, you probably wouldn't want to use vancomycin for that person. You may want to use something else like daptomycin or linezolid. The way I remember this is that Enterococcus is a poop organism, and it would be really bad to have poop on your face. So that the faecium is the worst one that's more resistant, okay? Generally speaking, for this infection, 10 to 14 days of antibiotics. As your patient gets better and clears up, it's probably more than enough. So I'd probably err on the side of 10 days for that. So bacteremia, our take-home points is that unlike the old days where it was like everything got 14 days, we can really shorten these durations up for uncomplicated illnesses where you get source control, your patient is getting better, and it's not Staph aureus, basically. So consider a shorter course of 7 to 10 days. And then stop the antibiotics. For Staph aureus, it has to be at least 14 days of IV treatment, and that's only if it's uncomplicated. Otherwise, it's longer. If you have an explanation for the bacteremia, that's good. That helps you feel like you can treat for a shorter duration. If you don't have an explanation, worry about an endovascular source. And then consider following up after that critical result call about your PCR result in an hour, because that may help you really direct your treatment. So you might wonder, well, why that kind of weird interlude about bacteremia as part of an antibiotic stewardship presentation? Well, it turns out that when we talk about antibiotic stewardship, there are core elements to antibiotic stewardship, and one of the core elements is education. So providing education about antibiotics, prescribing, and decision-making is a part of how we enact a stewardship program. Generally speaking, stewardship is about giving the right treatment at the right time, at the right dose, for the right duration. And the goal is to minimize the risks, the burden, the toxicity, the costs, C. diff, and then emerging resistance. And you might remember our friend Dr. Ricardo Arbulu, who said, unlike other drugs, antibiotics not only have an effect on the person, but also on the society and the institution. So when we give an antibiotic to our patient in front of us, we affect the broader ecosystem. I sort of think about that a little bit like energy. My daughter was asking me to explain what is antimicrobial stewardship, and I said, I want you to think about it like the lights in the house. So antibiotics save lives. They're important, and we use them every day, and I'd say energy is useful. We all like it and appreciate it and does us good. Antibiotics cost money, so does energy. Antibiotics have toxicity, so does energy. So from mining and everything else, infrastructure, and then antibiotics can have resistance that emerges, and over energy use can have climate change that emerges. So when I was explaining this to my daughter, I said, well, if you have left the room, the reason your parents give you a hard time about turning off the light is all of these reasons. We want to save energy because we don't want to waste money. We don't want to have environmental consequences from overuse, and we want to help the broader picture. And it would be very strange to say, I'm just going to leave the lights on in my house just because. But on the other hand, my daughter's 13 and she's very busy and she has a lot of things in her head that she's worrying about. And so she doesn't always think about turning off the lights. And so having someone there to help remind her and create those habits is an important part of learning and growing up. So stewardship is similar. This is a list of different types of antibiotic toxicities that we see. We're familiar with C. diff and more resistant organisms at the bottom. Most of us are familiar with kidney injury from vancomycin or other antibiotics, and also rashes. There's a whole host of things that antibiotics can cause. They're not all particularly likely, but taken in aggregate over the course of a whole institution or over the course of a whole state or nation, you can see major toxicity related to overuse. So hence the reason we try to not overuse them. This is a state-by-state antibiotic prescriptions per 1,000 person. This is in the outpatient realm. So you can see Iowa is sort of on the heavier end of antibiotic use. Not the worst, but definitely not the best. So we have some space to improve, generally speaking. So antibiotic stewardship as a program is, it's meant to help. It's meant to support our providers to make good decisions. It's meant to look at high-level data and analyze trends, and it's meant to optimize care. It is not meant to be inflexible to providers. It's not meant to be pejorative, and we know that antibiotics save lives. So Dr. Karen Carlson used to give us a hard time when we would come to her with stewardship advice. But I think the point was that we're not trying to bother physicians so much as we're trying to be supportive. And another thing about stewardship, for what it's worth, is it's not part of the permanent medical record. So these are staff messages and Post-it notes because, again, it's meant to be advice. And physicians know their patient and they know the clinical scenario. The stewardship team is looking at the chart, so our information is much more limited. So there are times when physicians may not take the advice. Stewardship's been around for a while. They were talking about it even when I was in my residency training. But it really emerged in 2014 when CDC called for a nationwide program. They specifically have said there's no single template that will work for everyone because everywhere is very unique. For example, there are large, small, urban, rural, specialty, safety net, and tertiary hospitals. Or, Mary Greeley, we're kind of in the middle, right? We're not small, we're not tertiary, we're kind of an in-betweeny type hospital, which creates its own sort of unique challenges. So these are the 7 levels of the core elements of stewardship. So first off is hospital leadership commitment. So primarily that's related to just takes resources to get this stuff done. And I think Mary Greeley has been incredibly supportive of these efforts since our program started in 2013. Accountability, we'll talk a little bit more about our program here. Pharmacy expertise is key to all of this. and then action, moving into not just watching what's happening, but intervening upon things, keeping track of good data, reporting that data out so everybody knows it, and then the education piece. So there's a number of different programs available for antimicrobial stewardship training. This is particularly geared towards pharmacists who end up being the real chairs of these programs and committees. And that sort of makes sense because when you think about antibiotics, so much of it has to do with about dosing and understanding the antibiotics. So this is a very natural part of pharmacy training to begin with, and they do a real fantastic job. A couple interesting things is people are familiar with vancomycin. We measure vanco levels to make sure they're correct. We don't measure a lot of other antibiotic levels. We presume we know something about the way the body's metabolizing them and they're predictable. But there's sometimes things about that metabolism that we don't know or don't have a way to measure. So there's some general truisms in infectious disease, which are if it's working, keep it going. And if it's not working, change it. It's not rocket science. And then Michael at the university, you always used to say, remember that if you give the right antibiotic, the patient will get better 90% of the time. If you give the wrong antibiotic, the patient will get better 60% of the time. And why might that be? Well, your patients have immune systems. They get fluids when they come into the hospital. So there's more going on than just the antibiotic. But the reason that's important is it can lead providers to draw false conclusions about what the antibiotic has done. So if a patient comes in with a vasovagal event and a reaction to an antibiotic and or blood pressure medicine, they're a little hypotensive, not sure what's doing it. So you start an antibiotic wondering about sepsis, but they also get fluids and then the blood pressure medicine is stopped and then they get better. The false conclusion is that the antibiotic got them better, but there's actually way more going on than just the antibiotic. So remember that if you didn't find an infection, it's okay to reevaluate and decide it wasn't an infection. So our stewardship program, you may remember Dr. Arbalou and then Gary Bailey, our pharmacist who started the program in 2013. They have both moved on. And so these days, the program is run by Jill Bodie, who's here. Thank you, Jill, for all your work. And then infectious disease is a key player in the committee as well. And then we receive guidance from both PNT and the infection prevention teams. And we actually have multiple pharmacists trained now for antimicrobial stewardship. We meet weekly to talk about challenging cases, guidelines, and different areas that we're focusing on, like order set development. And then they are working daily on reviewing antibiotics and providing prospective feedback. We meet as a whole group every other month. That includes lab, and then we meet with our infection prevention team as well, because the best way to treat an infection is to prevent it from happening. This isn't part of the core elements, but it should be. Lab involvement in this process is so important, from being on the cutting edge of technology to maintaining the antibiograms, to working with our team to not report certain antibiotics if they're high risk, and then collaborating with testing stewardship. We don't want to over-test in a low-risk situation. So they're essential, and you may or may not have heard that our lab just won a national award, best lab in the country. Phenomenal. So good job to you guys. We appreciate working with you every day. So I feel like that could be an eighth core element of heavy lab involvement. I think it's worth noting that CDC provides specific guidance for small hospitals and rural hospitals because they may not have the same level of resources that larger hospitals have. And I'd also like to bring up outpatient antibiotic stewardship, in part because it's a whole different ball of wax. It's just completely different. If you imagine inpatient, you have the pharmacy, you have pharmacists, you have the labs, it's all in one place, and you have the ability to have a degree of control and better data management. Outpatient becomes much more challenging because you may be having prescriptions coming from all different directions, all different pharmacies, different labs. How do you sort of get a grip on that? And so Dr. Killian and her team have made good efforts on the clinic side towards starting some improvement projects. And basically, there's 4 core elements for the outpatient side, which is a commitment to do it, some action project, some way of tracking what you've done, and then educating providers. But I do think the challenge of outpatient stewardship is part of the reason why it's not a high area of focus, just because it's a lot harder to manage. If you look at the total antibiotics that are given in the United States, there's actually way more outpatient antibiotics than inpatient antibiotics. But it's just a harder thing to get your head around. If you look at these guidance or core elements, I think looking at the action one, I mean, to me, that's always an important thing of what are we actually doing to try and improve things. And there's 2 main things that come forward, and one is pre-authorization, so not allowing the antibiotic to get given in the first place, and then one is prospective auditing and feedback. And I do feel like antibiotics are a very strange thing. We always say we don't have enough of them. We always wish we had more different types and better types, and then as soon as a new antibiotic gets approved, we restrict it and we won't let anybody use it. Which, if you were a company thinking about making a new antibiotic, that might be a huge disincentive, because it's going to be hard to sell a bunch of your antibiotic because people like me are going to say that doctors can't give it. That has to do with not wanting resistance to develop. That has to do with the costs of the antibiotics and having better alternatives. But so, for example, here we do have a restricted formulary for some antibiotics. And if these are antibiotics you haven't heard of or you're not very familiar with, that's because we really don't use them hardly at all here. These are antibiotics that are designed for highly resistant infections. And we just, fortunately, here in Iowa are not seeing those to any degree like they are, say, in New England and in other places. And some of these are restricted just because of the degree of toxicity that they confer if they are given. So generally speaking, we require pre-authorization for these antibiotics during the weekdays when infectious disease is on call and available to approve these. If it's on a weekend, actually these are able to be given by frontline providers, and then a pharmacist will review the indication with them. But so we have kind of what's called a hybrid restriction program where often providers, if they wanted to, would be allowed to give the first dose, but then there would be a quick follow-up from our stewardship team to say, is that really something we need to continue, or are there better options? I don't really think we get into a lot of restrictions here from a practical standpoint. Anybody that's gone through an infectious disease fellowship, though, restrictions are the bane of your existence, because the ID fellow holds the restriction pager and gets called all night long about, hey, I want to give this antibiotic. And you have to say, well, why? And tell me. And anyway, I'm glad we're done with those times, personally anyway. We more rely on prospective audit and feedback, where we are looking at provider documentation, we're looking at culture results, and then we're providing feedback to providers through messaging or Post-it notes in the chart to provide advice. So what are our teams, our stewardship teams looking at? So this is an example of some of Jill's data set. So we pay a lot of attention to SAR, the Standardized Antimicrobial Administration Ratio. And what that does is it takes an established baseline for peer institutions that are similar to us, and it sets the average, or kind of the expected amount of antibiotic usage at 1. This is actually based on 2017 data. It hasn't been reassessed since then. It's usually reassessed every 2 years, but COVID has thrown a huge wrench in that process. So you can see, if you look at our antibiotics overall, we have consistently been below the 1, the expected amount, and we do see this kind of light trend upwards, which we attribute a lot of this to COVID-related antibiotic use. We can also look at this specifically for different units and departments, and 3 cheers for pediatrics, who has made a lot of progress with antimicrobial use, and that's been through some of the leadership by Dr. Hufford and their team to try to eliminate and standardize some of their antibiotic approaches. And frankly, some of it was not as many kids were coming in with respiratory viruses because of social distancing and COVID. So it'll be interesting to see where this goes next year. We can also look at specific antibiotic classes. So this becomes very helpful because over the years, we've established what I consider our own baseline. So that's not exactly the SAR, but we kind of know where we run. And so you can see here, what happened here? All of a sudden, this line went bonkers. So we went back and looked. And so that was antifungals. And what happened was that with COVID, as it was coming on, we started giving immunosuppressing medicine, and we started thinking that we should give people antifungal prophylaxis with that. Well, that decision got made and then got lost track of, and antifungals were just being given basically to all sorts of people who had COVID. We reviewed the literature, and we saw that it didn't seem like that was adding any benefit from a prophylaxis standpoint. And we circled back and we stopped that practice. And since then, our fluconazole rate has gone back to normal. So we can do this across the board with all sorts of different antibiotics, watching specific classes. And if all of a sudden we see that our anti-pseudomonal antibiotics have gone way up on such and such a ward, we can follow up on that and give targeted feedback for whatever reason that's happening. We can also use the data to look for specific correlations. So for example, this yellow line is our C. diff rates. Well, why do people get C. diff? Generally speaking, it's from too much antibiotics. And so you might say, well, stewardship programs should be able to decrease how much C. diff we're seeing. So we actually graphed that out based on high-risk medications and antibiotics for C. diff, and we saw that there was actually no correlation between C. diff rates going up and antibiotic usage. Breaking that correlation then allowed us to say this must be something else that's going on here. We did a deep dive with the microbiology lab, and we found out that we were testing for it in the wrong way, or at least some people were. We redid our C. diff testing process, and our rates have come back down into the sub 1 range. So it was a testing stewardship phenomenon that we needed to work on. We can also look at what types of advice our stewardship team is giving to providers. So stopping antibiotics, you can see, would be a very useful thing, and that's been over the past 6 months really our main intervention. Dosing optimization, IV to oral, de-escalation, testing. I want you to notice this green, escalation. This is actually one of the most important things we do. Sometimes we find that patients aren't on the right antibiotic and actually need more of an antibiotic. And that's really a life-saving intervention, if you ask me. The reason this is important is we want to know what types of interventions we're making because we want them to be high yield. If we look back several years ago at some of the interventions we were doing, we noticed that a lot of the interventions were just recommending more testing. Well, more testing can be helpful, but it's not actually a hard outcome for your patient because you're not changing necessarily the antibiotics. And so focusing more on the de-escalation and the stopping or starting parts of the program, I think, increase the yield and also build more trust with providers. As a part of that, a lot of stewardship is about the relationship and the trust between the program and the providers. So we keep track of what's our percentage acceptance rate on antibiotics. And so over the past 4 months, you can see that we've been in kind of the 80 to 90 range. I think traditionally we've been around 75%. And you might say, well, who would say no to a piece of advice? Well, maybe we recommend that there's a bug-drug mismatch and we recommend stopping, or we recommend switching the antibiotic. Well, the provider might say, well, actually, I've decided that this patient doesn't have an infection at all. I'm stopping the antibiotics. I'm not taking your advice of decreasing. So we make a recommendation, yes or no. We'll keep track of if it's accepted or not. Sometimes we may say you need to give more antibiotics, and they may say, well, actually, the patient is, transitioning to hospice, so we're not going to give any antibiotics. So there's just a ton of clinical circumstances. Another common one is we may say switch to orals, and the provider say, well, yeah, but my patient vomited this morning. Well, that's not in the chart for the stewardship team to see. So we know that what the frontline providers know is more than us. And our goal is to just be providing a firmly grounded advice about antibiotics. So here you can see that's really what we're going for. Don't use nitrofurantoin for pyelonephritis. Use an agent that actually works at that site. Or use something that, advice that's firmly based in guidelines. What we try not to do is give advice about vague things. So the patient has an elevated BNP, they're getting diuresed, the procal was negative, but they did have some fevers when they came in and the chest x-ray is read as pneumonia. Well, that patient probably has heart failure. Who knows what the fever was? The chest x-ray might have been misread, but this is not an example of where we're going to call you and tell you to stop the antibiotics, because this is too vague. And as the physician, you need to be able to make good decisions in the setting of uncertainty. And so we try to only be giving advice when it's something that's very clearly based on guidelines. The doctors know their patients best. This is just an interesting high-level view up until a couple years ago, where since the initiation of our program, we were decreasing the number of antibiotics given total in the hospital. We don't actually have this data available the last 2 years, but I would be almost certain that it's gone back up again related to COVID. This was the financial related outcomes. This is the cost per patient per day in antibiotics. And you can see since the start of our program, it was coming down. I would say that also almost certainly went up with COVID. And, I think we just want to pay attention that these are complex systems. It's hard for providers to really, it's not that providers aren't doing their job. Medicine's becoming more complex over time, not less. And so stewardship is a safety net in a way to just focus on this one particular issue. And then we do our best to keep track of different outcomes over time. I'm going to move past our antibiogram. This just shows that we don't have a lot of high-level resistance yet in Iowa, as opposed to, say, in the Northeast. When I talk with Arbulu now, he's using those kind of unusual or heavy-hitting antibiotics every day in his hospital because they have so much more resistance there. So far, we're lucky. It would be impossible to talk about stewardship without mentioning that 60% of all antibiotics are given in agriculture. Because of antibiotic stewardship programs and the focus about resistance, there was a major intervention a few years ago to encourage less antibiotic use in agriculture, and there's been a dramatic decrease compared to where it was starting to peak in 2015. That has persisted now the last few years as well. We are working on a number of other projects over time. We have updated our vancomycin dosing program. We have updated order sets. We have empowered the pharmacy to move once-a-day antibiotic dosing more to the morning so that it doesn't hold up discharge. And we're integrating with NHSN regarding kind of the antibiogram and the SAR data. And moving forward, the question is, well, how do you know what's next or what's the next thing to do? And the CDC actually provides a 50 bullet point checklist of things that you can be working on. And so we have this in a spreadsheet of, are we doing this, yes or no? And we're always trying to move a new thing every couple months into the yes column. Some of them we can't do because of our setup here. But for programs that are looking for how to move their program forward, going to this website down here, looking at that tool can give a lot of direction. Our sort of future projects are looking at automated stop dates for antibiotics, and we're building those into our order sets, and also allowing the pharmacy to do more automatic IV to PO conversions for our highly bioavailable antibiotics that get to the same level whether they're given IV or oral. That's not true of all antibiotics, but we would empower them to just do it here. So those are some of the things we're looking at. Generally speaking, with stewardship, if you just focus on these three areas of antibiotics, it accounts for the grand majority of antibiotics that are given in a hospital. And so what we can do is create order sets that optimize choices. We can optimize the testing so that we get to the answer quicker and where we need to be. And then we can provide links and guidance to optimize that. Any of these things could be multiple talks on their own, but from just a high-level pearls standpoint, for community-acquired pneumonia, For the average person, you don't have to give them MRSA or Pseudomonas antibiotics. Those aren't in the guidelines. Unless they have risk factors for them, you don't need that broad or high level of antibiotic. The guidelines changed a few years ago saying that for aspiration, it used to be thought you had to treat for anaerobic organisms, and you really don't need to do that anymore. So using, for example, cephalosporins alone for pneumonia is an appropriate thing to do. If you thought that you needed MRSA treatment, doing an MRSA nasal PCR, working with your lab to get this program up and running, you can eliminate a lot of vancomycin just by checking somebody's nose for MRSA. If they don't have MRSA, they don't have MRSA pneumonia. If you do find MRSA in their nose, that doesn't mean they do have MRSA pneumonia, but it's a very good rule-out test. And study after study now is saying that for pneumonia, treatment for 5 to 7 days is adequate. That's really hard to do because, like, your patient comes in, they're really sick. 3 or 4 days later, they're starting to get better. You're starting to talk about sending them home. And, like, who sends their patient home for 1 day on antibiotics? Like, everybody says, here, take a week because you want them to get better, but you don't need to. So sending somebody home on just 2 or 3 days after their hospital recovery has been shown in study after study to be accurate and effective. And if you don't know if your patient has pneumonia or not, maybe there's other diagnoses that are being considered, get a procalcitonin. If it's totally negative and you think your patient might have heart failure, that can reassure you, and you can consider stopping your antibiotics sooner than you might have otherwise. This is a discussion from the pneumonia guidelines about procalcitonin. It's not going to answer your question on its own, but taken in context, it can help you. For UTIs, there's actually 3 separate guidelines. 2 of them are over 10 years old now, so they're being updated, and that usually takes years. Starting at the bottom, Foley-associated UTIs, the guideline pretty much says get the Foley out, don't put the Foley in, like just try not to have a Foley. That's the main take-home from that guideline. Uncomplicated cystitis and pyelonephritis, this is the box of treatment options, and I do think that first-line treatment for cystitis, uncomplicated cystitis, has sort of achieved liftoff, and I think most providers are using these options now. Nitrofurantoin for 5 days, TMP sulfa for 3 days, or fosfomycin as a single dose. If you do have a catheter-associated infection, I feel like my training said that's complicated. It has to be 14 days. Really, 7 days in a patient that gets better right away and you change their Foley is enough and doesn't have any decreased risk of relapse or increased risk of relapse. For people not familiar with fosfomycin, we often don't think of it because we don't frequently do susceptibility testing. But it is really effective against E. coli, which is the main cause of uncomplicated cystitis. So it's a one-time dose. Basically, pay attention. If your patient doesn't get better, then you'd have to circle back to another option. Cure rates, though, are on the order of 70%, and it's a good option and is also active against some of these very resistant organisms, even a carbapenemase producing, Klebsiella, 60% sensitive to fosfomycin. So sometimes it's kind of the secret back pocket antibiotic for your more resistant, uncomplicated UTIs. And then for cellulitis, if there's no purulence, if there's no pus, it's just this bright red leg and the patient's sick, that's almost always strep. If there's pus, that's almost always staph. So if your patient has strep cellulitis, you don't need to give vancomycin. Giving a more focused cefazolin is adequate, and I think we've got good uptake of that here. If the patient's septic, it's okay to start broadly. Often they don't manifest the cellulitis until the next day, but as soon as you see they have a non-purulent cellulitis, narrowing antibiotics to that first-generation cephalosporin is a good idea. I find this one challenging. 5 days for cellulitis, maybe for mild cellulitis, but I think many have seen really severe cellulitis where the leg is super inflamed and there may be bullae. And even in that setting, the antibiotics after 5 days have really killed the bacteria that are there. And what's left over is the toxin that's just kind of sitting in the tissues, causing that burn-like look to it. So shorter durations of antibiotics, you don't want to treat with antibiotics until the cellulitis is gone, because you'd be doing it till the redness or inflammation is gone, because your patient will be on antibiotics for weeks. So yeah, 5 days, 7 days, something like that. Shorter durations are okay. There's been a lot of interest in unique antibiotics. So this one we have on restriction, but partially it's a great antibiotic that doesn't quite have the right niche to use yet. So dalbavancin and oritavancin are long-acting, kind of vancomycin-like drugs. So if you think of what vancomycin treats, if you give dalbavancin, it's like having your patient on vancomycin for a week. So these are approved for skin and soft tissue infections. And their niche, as advertised, is you have somebody in the ER, they have not gotten better with oral therapy, give them a dose of dalbavancin instead of bringing them in the hospital. The challenge is that most people that get to that point are sick enough they need to be in the hospital for supportive care. On the other hand, if your patient just showed up to the ER or clinic for the first time, you can probably treat their cellulitis with a different oral option that's cheaper and less expensive. So this is a great antibiotic that we use if we have a patient that we don't think is going to be capable of taking oral antibiotics after discharge for various reasons. And so we'll give this to them on discharge and follow up with them a week later, and they've really been on an IV antibiotic that whole time. So it can really aid in early discharge. I find them very safe. We don't see a lot of reactions to them. Because they're long-acting, I often will pre-treat people with a little bit of Benadryl before I give it. And I have used these drugs for deep-seated infections and given it weekly for 3 or 4 weeks in a row. But that's usually if there's some contraindication to, having a PICC line in or other things. So when you think about infections, think about this curve. So what is the % chance of relapse of this particular infection as I give my antibiotic over time? And this curve will look different for every type of infection that there is. So if you think about strep throat, for example, if you give penicillin for 2 days, your chance of relapse, if you stopped it, is going to be way down after just a couple doses. On the other hand, if you think about endocarditis, you don't start to see a real benefit until you get out weeks of treatment. But the goal of any antibiotic treatment is to get your patient to right here, where there's no more benefit. You're not making the curve any lower, and you don't want to give the antibiotic longer than you need to. And then you have to balance this against toxicity that builds up over time. The challenge is that we all rely on our heuristics, our sort of patterns of treatment. And so if you're used to treating an infection that only requires 7 days of treatment, but you treat for 14 days, you're going to feel good about your outcome. Your patient isn't going to have relapse, but they weren't going to have a relapse even if you stopped 7 days ago. So whatever good you were going to get, you actually got it before. So that's why looking at these duration changes and as they get studied and shortened up is important. So stewardship programs improve outcomes, decrease toxicity, decrease cost, decrease resistance, have all of these benefits. Medicine is complex. There's just a lot of moving parts at all times. And think about stewardship programs like a mat or a spotter underneath a gymnast. So we don't see our high-level Olympic gymnasts doing gymnastics without mats. They still use them, and they are fantastic at what they do, just like physicians and providers are fantastic at what they do. The point is to give that extra level of support to focus on a particular thing that is of very high value to the patient and to the system. I would encourage everybody to just revisit your patterns of practice and what your antibiotic practice is, and be realistic about, gosh, I know it's hard for me to stop cellulitis treatment at 5 days. I usually go for 10. As much as it hurts me not to use a sports score, consider decreasing to 9 days. See what happens. And if you don't see any negative outcomes with that, get down to 8 days and test yourself and test your outcomes a little bit, because the data is there and it supports using shorter durations than I think what we're used to. And finally, good data drives good decision making. That takes time. So if you're looking to build up your stewardship program over time, you need to invest in it. And we have a lot of gratitude for Mary Greeley and the effort they've put into helping this program be good and effective. And I think our patient care has improved with it, and I'm happy to be involved. So So I think with that, we'll stop. And if there's any questions, I'd be happy to take them.
Could you explain how an intervention by the pharmacist is triggered? Is it a diagnosis? Is it the patient's antibiotics? How does Jill decide to review a case versus not review a case?
That's a great question. So we have an antibiotic census. So we know every antibiotic that's given because it's controlled through the pharmacy. So we actually have a generated list of antibiotics that are given every day. And so what we do is we look at that patient's chart and do a quick assessment of, this patient's getting levofloxacin. The indication is Staph aureus bacteremia. That's a no-no. Like, you never want to do that. So then, and often it's just kind of a high-level look at first, and then you drill down and drill down. And sometimes you find it's just too vague and you can't get to an answer. And at that point you say, this doctor's doing their job, let them do their job, stay out of the way. But sometimes you say, maybe this extra data came in, they might not be aware of it. We're going to give them a little nudge and say, hey, did you see that? This is what we'd suggest. So it's an ongoing process. So it's a resource intensive process. And there's been estimates that for stewardship programs, per 100 beds in the hospital, the institution should be dedicating one FTE of pharmacy time per 100 beds. And so we have 200 beds here. So you kind of think about 2 full-time pharmacists kind of doing that. I mean, I think we have kind of a distributed program where multiple pharmacists are working on it all the time. That's different than the days of Gary Bailey, where he kind of was doing it all himself. I actually like our program. I think it's allowed more people to be involved. And we have actually increased the number of interventions we've had since we switched to a more kind of distributed system. Jill, did you have anything to add to that? Did I answer that?
That's absolutely right.
So for anybody that couldn't hear online, Joe Bodie was just saying that we also prioritize based on the risk of the antibiotic. So for example, if somebody's on clindamycin, we'll look at that one first, then broad spectrum Zosyn and such, and then kind of prioritize in that way. Well, thank you everyone for coming. I really appreciate it. And all of you that help with this program, I really appreciate that too. Thank you.